like to welcome you all here this evening, coming to my town meeting regarding Death with Dignity Forum or physician-assisted suicide. It will be a discussion of the pros and cons of this particular issue. I'd just like to thank Cortland, the town of Cortland, so much for providing this wonderful space, which they so often do, and for the staff who puts it all together for us, which is great. And also the co-sponsors of this event, the Westchester Independent Living Center, the Hudson Valley Chamber of Commerce, the Buchanan Seniors, and the Bethel Nursing Homes. Now, you may be wondering why I decided to have this forum on this very critical and emotional topic. We started getting emails in my office. I have to tell you, I probably get about 200 emails a day on different topics. And we started probably, I would say, at the beginning of the year of 2015, getting emails from my constituents and expressing their views on legislation that's been introduced by some of my colleagues. And it's been pro and con, the emails that are coming through. And so knowing that 4 states, Oregon, Washington, Vermont, and the latest California, have adopted legislation, and Montana and New Mexico has done it through the courts, it is clear that the discussion is beginning in New York State. Now, it may have happened in New York State, I think probably in the mid or late 90s. There was discussion about what we do in the area of physician-assisted suicide. And so it has been highlighted a bit by a case in California of a young lady, Brittany Maynard, who moved from California to Oregon to determine her choices. She was a 29-year-old and facing a fatal diagnosis of brain cancer. And so that kind of brought it back into the press, I guess. And so I just want to tell you, once I sent out my newsletter announcing and emails announcing this forum, I got a lot of emotional ones back, both sides of the issue. I just want you to know. I'm trying to, keep a little bit of a diary on what people have said. We've also had some chats in Albany with a number of lobbyists that came up last spring on the topic. So, it is very emotional, and I think I feel emotional about it right now. It's a very difficult issue. My goal is to have a pro and con debate, bring out the facts, the positions, all sides of the question about physician-assisted suicide, and I will perhaps personally have to take a vote at some point on this legislation, and I personally want to be informed, and I would hope that my constituents also want to be informed. There's some handouts on your chairs, or you may have picked them up at the door. One, I was asking if you would fill out before we start the discussion. And it's this paper here. And if you don't have any, I have Jen Teweel is in the back of the room. If anybody doesn't have one of these, just raise your hand and she'll get one too. Because I really kind of wanted to know how you felt when you walked in the room. And then at the end of the meeting, if you could tell me, do you feel the same? Did one of the speakers convince you one way or another? Just so I have an idea of your thoughts. We do have a basket in the back of the room that you can leave these, just turn them upside down, and you don't have to put your name on them. You can if you want, whatever. That would be very helpful. Also, there's some handouts. This lavender one tells you about our agenda for the evening, and we are going to be having our 4 speakers make their presentations, and after that there'll be questions from the public. So we'll just let them get through their presentations first. And also, you probably picked up, is their bio on our 4 speakers, so I'm not going to read their whole bio, but it's in here. And I'm so pleased that we have such a great panel tonight. We are videotaping, so that we will have a CD available for anybody who would like a copy. You just have to call my office, and we will get So we won't have it tomorrow, but you can call the office and we will get it to you. Our speakers include Dr. Mildred Solomon, who's to my left. She's president and CEO of the Hastings Center. Bruce Darling, who is this way, CEO of Disability Rights, Not Dead Yet. And Corinne Carey at this end. She's the New York Campaign Director for Compassion and Choices. And Dr. Ira Bedsoe, who's the Director of Biomedical Ethics and Humanities for the New York Medical College. As you see with the speakers, you're going to hear different points of view. We will start with Millie Solomon, president of Hastings Center, which is in Garrison. It's just kind of right up Route 9. So, and I've gone to many of their events, and they do deal with multiple topics, ethical topics, healthcare topics, and they have very interesting programs. So I thank you very much, Millie, for coming tonight.
Thanks so much for having me. Assemblywoman Galef organized a really terrific panel tonight, and you're going to hear a lot of divergent views on a very contentious issue. But she invited me to do something a little different. I want to start by sharing with you what's currently ethically and legally permissible around decision-making near the end of life. What does the law say now? What do existing ethics frameworks say now? So that as you think about your position on this very cutting-edge issue of legalizing aid in dying, you know what is actually legal and ethical now, and people are aware of their rights, because it's very clear that we often don't know what our rights are right now. And I'd like to leave you with some thoughts about how you can better take advantage of the existing status quo, not to argue against physician-assisted suicide or for it, but just so we begin with a clear understanding of what's happening and why are we here facing these kinds of decisions. The why we're here question really is an historical question. There's been a revolution in the way that we die. For thousands of years, humans died from infectious diseases or from injuries caused by accidents. And then something very recently, in the 1960s, changed, and that is medicine got better. We got a lot of technology and the ability to forestall death in a variety of ways. And now the epidemiology of dying, if you will, is very different. We in the developed world, primarily do not die from infectious diseases and accidents. The primary causes of death are chronic illness, which means that these are illnesses we have for many years, and we experience declines and enter a period of frailty. And at the same time, we have at our disposal amazing technologies. And they've created length to our, we have greater length of years, and we have more rescue so that chronic illnesses can be forestalled and we can live with illness for longer periods of time. Now, personally, I think I know and probably many of you are pretty happy that we live in this period when we have this kind of technology at our disposal. It can provide enormous benefits. But these technologies have also been called halfway technologies because they can't they sometimes can rescue us if we need to be on a ventilator because some urgent acute thing has happened and the condition is reversible back to a good state of health, then that's wonderful to have those resources available to us. But often they're, as I say, called halfway technologies because they can't really undo the underlying chronic illness. Death or decline will be inevitable, but they can postpone that period and sometimes postpone the dying process and bring burdens as well as benefits. So there's no escaping that in 2015, we actually have to be conscious about how we use these technologies, which means that we have to be conscious about things that used to seem like they were fate or determined by a higher being, actually are now in our lap. We have to decide when we're going to use them, when we're going to forego them, and when we may stop them. Now, these issues first came to the fore. As I say, this is really relatively new. I don't know how many of you would be able to guess what first brought this issue to public attention, or remember this cover, the cover story of Newsweek in 1975 with Karen Ann Quinlan on the cover. So this was the first notorious case. And it was notorious because, as I say, these are relatively new things. Humans didn't have to think about this before. In 1975, Karen Ann Quinlan, a woman in her 20s, was in a persistent vegetative state, permanent coma. It was clear and everyone agreed that she would never, unfortunately, be able to come out of that coma. And her parents felt it was undignified for her to remain hooked up to these machines, and they asked her doctors to withdraw a ventilator. The doctors and everybody else in 75 wasn't sure, would that be killing her? And eventually the hospital and the doctors said, well, we might consider doing this, but we want the blessing of the court. And so this case was the very first to make its way through the courts, very close here, and finally got to the New Jersey Supreme Court, and a landmark decision was made. And what the judge said in this case, and here's a closer view of Karen Ann Quinlan, what the judge said was, it wouldn't be killing, but we must try our best to make a decision based on what Karen Ann Quinlan herself would have wanted if she could see herself in this setting. And in fact, he literally said in the write-up of the case, let's imagine that she could for a moment wake up, be on the ceiling, look down at herself in the bed. What would she herself tell us? That's the standard we should use in making these terribly tragic decisions. And the parents felt very clearly that she would not want to be sustained, and the ventilator was withdrawn. Now, that began to establish a framework. In the 20 years that followed, there were about 200 other court cases, and most of them followed the same shape, that families were concerned that their loved ones were being overtreated or being kept alive inappropriately on machines. The next case that was very prominent actually went to the US Supreme Court, and that was the case of Nancy Beth Cruzan, another woman in her 20s, also in a persistent vegetative state, a permanent coma. This time, the question wasn't, could the ventilator be removed? The question was, could artificial nutrition and hydration be removed? And again, the court found that any kind of technology can be removed, no matter how technical or how simple, that people have the right to say no to the use of technology on their bodies, but that we should try to decide as the patient herself would want. And the other thing that came out of this case is that these rights are not, both these cases established that we don't lose these rights when we lose capacity to make our own decisions. If we become incapacitated, these rights are preserved in the form of proxies or surrogates, family or loved ones who we select to speak for ourselves. And the third case, of course, is the case of Terry Schiavo, which again was settled in exactly the same way, because this legal and ethical framework has been very well tried and true and is really established in the United States. And despite all the political furor around the Terry Schiavo case, and I'm happy to talk about it in the questions and answers, nevertheless, the courts were absolutely consistent in decision-making for that case as they were in the two earlier ones. What do you notice about this array? They're all young women in their 20s, as was Brittany Maynard. It's kind of almost, yeah, thank you. Eerie is the right word. So through these court cases and many others, we've established this legal framework. Not everybody realizes that they have the opportunity to say no. And of course, it's not only the law, there's been ethics frameworks. This was a special presidential commission that was formed in 1983. And then just a little later, in 1987, the Hastings Center, which is a neighbor of yours, we are just down the street on 9D, we came out with these guidelines, which were very consistent with the president's report a few years earlier. And then just in 2013, we updated that, and these guidelines are available. You can visit our website and find them for yourself. They're written for doctors mostly and nurses. They're guidelines for healthcare professionals, but they are very, very easily accessible to the general public. So I just want to summarize. What's currently ethically and legally permissible? What's the consensus on this? And yes, there will be controversy. There will be cases like Shivo. There will be political controversy. But the courts and the sort of ethics authorities that are turned to by healthcare systems around the country are pretty consistent that competent patients can choose to forego treatment. All types of life support can be withheld, even the most highly technological like ventilators or dialysis machines, but also the most simple, like chemotherapeutic agents or even antibiotics. People get to choose what is done with their bodies. And that right even lasts for incapacitated patients, and it's expressed through surrogates or proxies. The key that runs through all these cases is the best thing to do is to assess the relative burdens and benefits of the proposed decision as the patient would perceive them. What would the patient see? How would the patient want to live? And also, very importantly, that the right to refuse treatment, which is what I've been talking about, to say no to something, does not imply a right to demand it. And some of the most interesting recent cases are the reverse of what I've been talking about. There where people are saying, you must do something to the doctors, and doctors may be saying, but it's not going to be effective and we don't think it's appropriate. And that's more typical of some of the more recent kinds of cases. And again, I'd be happy to talk about that in the questions and answers. They're so-called feudal cases where the clinical team is quite certain that what's being asked of them is not going to provide any help at all, and yet families, for whatever reasons, are insisting and demanding. So that's another kind of case. So basically, so far, this helps by saying we're not going to impose technologies on people. And it kind of says we get to be in control of how much technology we're going to use near the end of life. What it doesn't do, and part of the reason there's an opening now to have the discussion about legalizing assisted suicide or aid in dying, is that the argument has been made, well, this is okay if a person is dependent on technology. We have created a framework in this country to have it withdrawn and be allowed to die. But what about people, I'm sure you will hear from Compassionate Choices, what about people who are not dependent on life-sustaining technologies? Shouldn't they have an option to exit life? And why should it be dependent simply on whether they're dependent on a ventilator that can be turned off? For example, very many advanced cancer patients may not be on life support, like Brittany Maynard, but they know that inevitably they're going to die, and they might not choose to become that frail. They don't want to hang in there through that level of frailty. And so they may argue that they need the right to physician aid in dying or assisted suicide because it's not fair that they wouldn't have an exit strategy, so to speak, just because they're not dependent on technology. So in a way, if you're dependent on technology and you have loved ones who know what you would have wanted, you have a route that they can help protect to create a less burdensome departure. But if you don't, then that's where the question about assisted suicide enters. I have a couple minutes left. I want to just leave you with some parting thoughts about, if you find yourself in a situation with family or friends where it's just not clear what the right thing is to do with respect to staying on a ventilator, going on a ventilator, getting dialysis, just as a show of hands, how many of you feel you've confronted treatment choices like that in your own family or with friends? Let's just see a hand. Yes. Isn't it good that Sandy Galef called this meeting? Just about everybody raised their hands. It's a human condition of our times, and we can't escape these choices. So I'd like to just end with a few thoughts about what we can do now, no matter where the state of New York comes out on the question of assisted dying, the legalization of assisted suicide or aid in dying, wherever New York comes out on that, the things I'm going to share with you hold true either way. And there's something that are rights and strategies and things to keep in mind right now. And so one is that sometimes technology is a great blessing, and we're so grateful. Just the last 2 months, the wife of a very dear friend would have died had it not been for ventilatory support that she got over a 6-week period. I'm so glad that ventilator was available. But it's not always, more is not always better. One area where that's very true is cardiopulmonary resuscitation, DNR orders, and they can be burdensome. People can break the ribs of frail elders. If doctors talk to you about CPR, you should listen to the difficult choices you'll have there. And I'll talk a little bit more about dialysis and nutrition and hydration in questions and answers. So obviously, one thing is to leave this hall and make sure you've designated a proxy if you haven't already. Talk to your proxy about what you'd want, and make sure you have copies of your advance directive just about everywhere, not just in your drawer. And then when it's uncertain what the best treatment choice might be, families should call for a meeting, and they should ask, what's the likely trajectory of my loved one's illness? Not just during the hospital stay, but be sure you say, what's likely to happen afterwards? Because unfortunately, frankly, the healthcare team in the hospital's goal is to get patients to discharge. It's not to say what happens after that, but actually what happens after that should be something you consider when you think about what kind of decision you want to make. And then, of course, inquiring about hospice if it looks like this is a terminal condition, because hospice can provide a great deal of support. So I'm going to leave it there, and we can pick it up after you hear the pros and cons about the next big question we're facing.
Thank you very much, Millie. And I wanted to let you know that some of our speakers have brought information that's on the back table that you're welcome to pick up. I don't know what they brought, and some didn't, but there is some back there. I regret that I didn't bring a designated proxy information or advance directive. So if you need something, just call my office. We will get that to you. We had an old one, and we thought that's not good. We have to have an up-to-date one. So I regret that. Now we're going to turn to Bruce Darling, who's CEO of Disability Rights, called Not Dead Yet. And Bruce has had a very long day. He started out in Rochester at 3:30 in the morning. He's already been to Albany for a press conference, and he's down here, and his eyes are open. This is good.
They
Bruce.
are. And actually, my experience in the disability community has opened my eyes to this entire issue. So I think one of the things I would like you to do is bear with me as I talk through the disability perspective on this. Some of what we talk about is going to be innately uncomfortable to folks who come from an able-bodied perspective. So I'm going to talk a bit about how the disability community is connected to this issue, but first I want to give you a little bit of background about who I am. I run the Center for Disability Rights in Rochester, New York. I'm not the CEO of Not Dead Yet, but I have worked extensively with Not Dead Yet, and I came to this issue through the lens of attendant services. So I work with people who have significant disabilities who require other people to assist them with the activities of daily living. So I don't know, have you guys had any experience with that? Show of hands. Anyone actually receiving attendant services? Okay, not. So I think that's going to be incredibly important to loop back to. The point where I really became engaged in this issue was about withdrawal of treatment. I was, the local news station came to our center to talk about a man who was on a ventilator. He had had a spinal cord injury at 16, went into the hospital, and basically got rehabbed. They sent him home, but this was years and years ago, probably 40 years ago now, and they weren't able to support him at home with his ventilator. Now, he wasn't trached. He used basically a mouthpiece to breathe and had a tent at night, so he wasn't trached like you might think of with a ventilator. At 48, he was profiled in the newspapers leading this amazing life in the hospital. Because they couldn't support him at home, he went back to the hospital and there was a trade made. The hospital was given the entire settlement from the accident in exchange for lifetime residence in the hospital. Yeah, you can imagine. Well, they actually, I think the hospital anticipated life expectancy was going to be a financial deal for them, and it didn't work out that way. Because 32 years, okay, so let's flash forward 30 years. He was profiled in the newspaper of leading an incredibly exciting life in the hospital. He had a computer, he was engaged, he was coaching people through the process of acquiring a spinal cord injury, so he was providing on-site peer support to folks from that perspective of having lived with this for 30 years. 2 years later, he turned 50, a milestone for many folks. His mother died, his computer broke, and the hospital wouldn't give him a new one. He was going through a very traumatic period of time, and what he said to the hospital was, "Shoot me up with morphine and let me spit out my mouthpiece and die." So there is a question here, and this is where the intersection of disability and terminal illness, he was not actually what one would think of terminally ill until he spit out the mouthpiece. So at that point, he really did and the hospital discussed this, and they decided ultimately that it was his right to withdraw treatment, which we don't disagree. The issue was whether they should shoot him up with morphine, which they decided they would do, and in fact, they did, and he died. Now, when I hear the story, I think of turning 50, my mother dying, my computer breaking, having no social connections. I think someone's depressed. This is a very difficult situation to be in. And the problem we have, and what I found, was that instead of looking at his situation, why wasn't he given community support services to go out into the community? Why wasn't he being given the support, the suicide prevention services that other people were given? Why was it everyone was saying, this is appropriate, you should die? It came down to the basic issue of ableism. People saw him as less worthy of life and of living simply because he had a significant disability. And I think that kind of was paralleled in some of the language that I heard. Looking down from the bed, seeing someone attached to a ventilator as being undignified. I think that those are some of the ableist views we have around these kinds of issues. So moving forward, when you look at why people are talking about assisted suicide, the issues often, actually based on the Oregon report, 91% say they are less able to engage in activities, 89% say they fear a loss of dignity, 50% say it's a fear of loss of bodily function control, which, okay, we all know that's very embarrassing. Well, actually, I do. And 40% say the feeling of being a burden. These are all fundamentally disability issues. These are the concerns that we have. We don't want to be a burden to our family. We don't want to lose control, but in fact, that's actually what the disability experience is. So the other part why this is a disability issue is because providing a blanket of immunity to doctors around assistance with suicide and people dying actually has been identified as a long-term goal to extend that to people who have significant disabilities. So Compassion and Choices, before it was rebranded, was the Hemlock Society, and their founder actually spoke about seniors and people with disabilities would rather die than go into nursing facilities. So let's give them what they want. From a disability rights perspective, that means attendance services in the home so that they can live an exciting life. He used that as the reason to promote assisted suicide. So let's talk a little bit. So some of the issue, the Bill White case that I was talking about related to disparate treatment around suicide prevention. This is fundamentally a problem that we have because everyone's thinking about this in terms of, someone who uses a ventilator. If you say, you want to die, you're going to get a fundamentally different response than someone who is perceived as able-bodied. So I can share some personal experience. And okay, before we get there, the problem is that doctors, who are the gatekeepers of assisted suicide, no offense to any of the doctors here, are the people who generally have biased opinions about people with disabilities. So studies have demonstrated that quadriplegics rate their quality of life basically the same as you or I, whereas physicians and medical professionals generally rate their quality of life extraordinarily low. So instead of interceding and providing suicide prevention when someone says they want to die, the response is to be supportive. I can take that to my personal life. So I have some experience with this because I am a gay man of a certain age, so I'm not unfamiliar with hospitals and all of the decisions that come around with this. But I look at where you all are as able-bodied individuals in making decisions, and I think to myself back in the early 80s. When I was looking ahead to growing up as a gay man, I had no role models that were positive or anything basically my entire thought process was about bias and stereotype, which is about what people have when it comes to living with a disability. So when I was considering whether I would live or die, if someone said to me, I could help you with that, there would be a very different outcome for where I am in my life, rather than saying, suicide is not the direction. You need to think about what you have potential and to be supportive. So I share that because whereas the LGBT community has reached out to young people who are considering suicide and saying there is life that you can live and there is life worth living, you are making your decisions based on bias. There is very little in parallel related to disability. You don't know what it's like to live with a ventilator, and the experience of folks in the disability community who live with these pieces of technology are they live full and enriched lives just like you or I. And that's the concern we have, is that this issue is not being addressed. All right, additionally, and then actually that goes to the issue of futility, which I'd love to talk about afterward as well, because when your doctors decide that your life isn't worth living, they may choose not to allow you to have the medical services that you want, and that may relate to ableism around their decisions about whether you have a quality of life worth living. Other points, there are mistakes in diagnosis. So people will get assisted suicide, we've seen this, who are not terminal. Doctors make mistakes. As I said, sometimes the decision whether a person is terminal is sort of based on the outcome. So I think about the gentleman most recently who was in Indiana. He was in a hunting accident. He fell from a tree. He broke his neck. They woke him up from the medically induced coma, and they said, "Your wife is 8.5 months pregnant. You will never hold your baby. Do you want to live or die?" He said, "Take the ventilator off." He would have been weaned, generally speaking, based on his prognosis, he would have been weaned from the ventilator and been what I would refer to as a garden variety quadriplegic. But we will never know, because basically his life was ended because people decided to cut it short. So he was terminal just simply by the fact that his life was being ended. There are inadequate safeguards. Doctor shopping. In Oregon, we see people doctor shop. If your doctor says he doesn't think you're appropriate for physician-assisted suicide, you can be given a referral from Compassionate Choices as to where you can find a doctor who'll be more amenable. That may be something that maybe you are not doctor shopping. Maybe it's your family member who's doctor shopping. Elder abuse is rampant. It is a serious problem. Family members can actually help you doctor shop. And in one case, one woman who was denied access to assisted suicide, the medication, her family member took her around, found a doctor who would do that, and actually then, it was a week after, she was placed in a nursing facility for a week, after which she then decided to take the pills. Well, or at least that's what we're told. We don't actually know what goes on, because when people get the medication, no one is there to witness the actual taking of the medication. No one is not necessarily there to see that this was self-administered. And in fact, some cases we know it's not self-administered. So it is altogether possible that some people will receive assistance in dying who don't necessarily want to die themselves, that this is done for them, or to them more appropriately. Individuals who have depression aren't screened out. So in some cases, people with mental health disabilities who should be screened out and given psychiatric support are getting assistance in suicide in Oregon. And there are economic pressures. I think one of the things, so we see this, I see that both as being a burden in terms of needing assistance from family members, but economic pressures. How many people have thought about, if I become ill, what is going to be the financial impact on my family? I mean, that's really, we all think about that. We are wired that way. But that is in and of itself a pressure that's going to be placed on individuals to choose to die rather than live with a disability. Our own financial concerns are serious, but when you mix this with managed care and the refusal of treatment, we're struggling now in a state. It doesn't affect all of you at this point, I'm sure, but we're struggling around assistance with managed care and cuts to services, refusal to pay for treatment. When managed care has a choice between paying for expensive chemotherapy and a $300 pack of pills that can end your life, what is the direction that managed care is going to go? And when you are denied services and supports, you're going to feel like you have no other option but to take the exit. Finally, I just want to say this isn't necessary. So suicide is not illegal. You can actually do this. There are lots of ways we've talked about, even people with significant disabilities. Pain, which is a significant reason why people think about assisted suicide, can be addressed through palliative sedation. There are definitely mechanisms that can address pain so you don't have to die. But if you want to actually exert more control, you have the ability to refuse to eat or drink, and you can get medical support through that process when you are terminally ill. So you can actually stop eating and drinking. You get to the same place. You die. It takes about 2 weeks. It may not be the immediate thing that people say they're looking for, and I'm sure some people figure that they don't want their family or others taking care of them for those 2 weeks because of those ableist views that we have about living with a disability. But at the end of the day, knowing that other people who are collateral damage to this policy will die, the question I have to ask you is, how many of them are acceptable? How many other people who didn't want to die or shouldn't have died are you willing to accept in order for you to try to make the process neat and clean for your own death? Is your control over your life and your death that important to you? Put that in terms of a percentage or a number of lives. All right, I'm done. Thank you very much.
All right, now we're going to reach out to Corinne Carey, who is the New York Campaign Director for Compassion and Choices. She came down to join us today from Albany. Corinne.
I'll start out by asking you a question. How do you want to die? It's a jarring question. Maybe you've thought about this for yourself. Most people answer this way. They say painlessly, quickly, in my sleep, surrounded by loved ones, at home. Sadly, very few people are granted this kind of death. In fact, 78% of people die in a hospital or in a nursing facility. Despite astoundingly advanced medical interventions that appear to be miracles sometimes, there is no miraculous cure for mortality. Death is a natural and necessary part of life. I know I've thought about that question, how do I want to die? I've thought about it a lot more in the past 2 years since I sat by my father's bedside and helped him through his painful and frightening, but mercifully quick death of lung cancer. That's my dad. By most accounts, he had a good death. He died at home with his family 36 hours after hospice came in. He was in pain, but it didn't last for very long. Modern medicine can save bodies that have been beset by untimely accidents or diseases in ways that we could not have imagined 100 years ago, 50, or even 25 years ago. But it also has the ability to keep bodies alive well past their expiration dates, sometimes seemingly indefinitely. When diagnosed with a fatal illness, our first instinct is to fight. And when that happens, intensive medical interventions escalate and people die in places and in ways that they would never have chosen. And it was only in the early 1990s that laws were adopted to allow people and their medical proxies to withdraw life-sustaining treatment at the end of life. The time has come for another advance in end-of-life care, allowing people to request medical aid in dying when they are terminally ill and they want the autonomy to die the way that they want. My name's Corinne Carey, and I'm the New York State Campaign Director for an organization called Compassion and Choices, the nation's leading organization working to improve care and choices at the end of life. Compassion and Choices works to ensure that people have a full range of options at the end of their lives, from the right to ask for aggressive treatment, to increasing access to hospice and quality palliative care, to aid in dying. I came to this work recently over 2 decades spent working in the field of harm reduction and HIV prevention, fighting to save people's lives through smart public policy changes. In the beginning of the AIDS crisis, it seemed like we lost everyone. I watched my cousin die a horrible death in 1992 in a hospital bed from AIDS. So many beautiful people before and after my cousin Billy were lost to that terrible disease. And we fought for access to antiretrovirals and clean needle exchange programs to prevent the spread of HIV. I now have friends who've lived with the disease for decades, and they've lived longer than they ever thought they would. I've lost countless clients, colleagues, and friends to drug overdoses. And so we fought for overdose prevention education, and we fought for access to Narcan. And now EMTs carry Narcan, and family and friends can have access to this life-saving overdose reversal drug. Those deaths were tragic and untimely and chaotic. They were lives cut short by preventable death that left acute pain and bewilderment. And now smart, compassionate public policies are in place that save those lives. But after the loss of my father, I came to the realization that sometimes you get, maybe when you're in your late 40s, that not all deaths are preventable with smart public policies. And my joining Compassion and Choices in this campaign is consistent with that earlier work. And it's because aid in dying is not about death. It's about life, and it's about how people live the final days of their lives. So you've heard a little bit about Brittany Menard. When she was just 28, Brittany experienced what thousands of Americans have. She learned that she had cancer, and she learned that it would kill her. And she experienced the same shock and denial and grief that people who've been diagnosed with cancer have. She turned all of her attention to finding a cure and fighting the disease. But when she learned that her cancer didn't respond to treatment, and that in fact it grew instead, she did something different. She did something courageous. She asked for the truth. She asked her doctors to tell her what her tumor would do to her before it killed her. And she decided she wasn't going to let that tumor do that to her. So she picked up and she moved her family to Oregon, where Oregon has a dignity law, and she requested the medication. And then she did a few really important things before she died. She spent time with her family and friends. She traveled to the Grand Canyon. She went to Alaska with her best friend. And then she started raising her voice in support of legislation authorizing aid in dying. She recorded videos, and she spoke with California Governor Jerry Brown for about an hour about how she would have rather stayed in California to die. When her first video premiered on People magazine's website, millions of people across the world watched it. Compassion and Choices had nearly 500,000 people visiting our website asking how they could help or get more information. And California responded. You probably know that Governor Jerry Brown signed California's aid in dying law on October 5th, just last week. So within a year of her death, Brittany actually took the medication to end her life November 1st, 2014, just a little less than a year ago. The California legislature granted her wish. California is not an outlier. New York lawmakers responded when they heard Brittany's courageous journey as well. Let me tell you a little bit about the legislation currently pending. We're in the middle of a 2-year cycle here in New York. The session begins in January and it ends in June. And in 2015, Compassion and Choices worked with Senator Diane Savino to introduce the End of Life Options Act. Assemblymember Linda Rosenthal from Manhattan also introduced legislation early in the session, and now her bill matches Senator Savino's. Late in the session, we were pleased to see that Republican Senator John Bonasek joined the crew and introduced his own bill, which is matched in the Assembly by Democratic Assemblymember Amy Pollins. A copy of the End of Life Options Act is in the back. Oops. So what does it do? It allows a terminally ill, mentally capable adult to request life-ending medication from a doctor that the person can self-administer or not at a time of his or her choosing. And the bill contains a number of safeguards. I'm not going to go through all of them here, but you see them up on the screen, and you'll see them in the legislation. Just a few: the terminal illness needs to be confirmed by 2 doctors. The bill requires that a referral to counseling be made if the doctor believes that the patient suffers from a psychiatric condition or depression that impairs his or her judgment. This is the kind of thing doctors do all the time. Every time they have to decide whether to administer medical treatment, they have to make a determination about whether someone has the capacity to give informed consent. So they are used to making these kind of determinations, and the bill requires it. The bill follows, just as every other one has, Oregon's model. And with evidence from Oregon's 17-year experience, we're confident that sufficient safeguards are in place. So let me tell you a little bit about Oregon. Here are some statistics about people who have accessed Oregon's dignity law. Just some things of note: that over 90% of people who accessed the law were in hospice care, and almost all of them had insurance. The median age of those accessing the dignity law is 71, with the range being from 25 to 96. Now, the really interesting part is that of the 1,300 some people who received a prescription for the medication, 35% of them never took it. See, this is about autonomy. And what we've heard from families in Oregon is that just knowing that you have the option gave patients and their families peace of mind. And some families, although it's hard to prove, but some families say that their loved ones lived longer with the comfort of knowing that that option was available. There's also a silver lining to Oregon's Dignity Act, and that is that end-of-life care improved. There was a 30% increase in referrals to hospice care. 69% of doctors took continuing education classes to improve end-of-life care. 70% were more willing to increase morphine dosage, and 76% felt better equipped at pain management. All of our states, New York State is no exception, we all have to get better at end-of-life care. There's no question about that. There was recently a report card released about the quality of end-of-life care, and it's important to note that the 4 states that actually have aid in dying laws got a score of A in terms of the quality of care that they provide to people at the end of life. New York got a B. I'd like to see us in that A category. If New York adopts the law, that's not going to be what pushes us to A. We're going to have to do a lot of work to improve end-of-life care. But enough about Oregon. Let's come back to New York and talk about what New Yorkers are thinking. We released a poll last week. We did a survey of 1,000 registered voters in the state of New York. And that sample is reflective of the voting electorate by gender, age, political party, and region. And we found overwhelming support for aid in dying. Allowing a terminally ill, competent adult the option to request aid in dying is strongly supported by New York voters, no matter how you cut it. Clear majorities extend across all lines: upstate, downstate, liberal, conservative, people of faith. 77% of respondents supported access to aid in dying. And after they learned about some of the opposition arguments and more about the bill, that support increased to 81%. Even self-identified conservative Republicans support the legislation at 65%. But of course, we have opponents, and it's going to take a lot of effort to overcome that opposition. I'm going to tell you a little bit about it beyond what you've already heard. I'll talk about organized religion, organized medicine, and some of the disability arguments that were addressed by Mr. Darling. Perhaps our strongest opposition will be the Catholic Church, no surprise. But Catholics themselves support aid in dying. Our poll found that 74.8% of voters who identify as Catholic in New York support aid in dying, even among those who attend church weekly or more than once a week. That number was still, among those folks, 61%. And I wasn't surprised by those numbers. I'm Catholic, And my own family, when I got this job, I was a little nervous when I called them and told them that I was going to be applying for this kind of a job. But I was stunned at the level and depth of support that my family showed for this issue. You know, one of the things that I found so striking was when Governor Jerry Brown signed the law, he said something that my mother said. I thought, did my mother talk to Jerry Brown? But this is what Jerry Brown said. He said, "I don't know what I would do if I were dying in prolonged and excruciating pain. I am certain, however, that it would be a comfort to be able to consider the options afforded by this bill, and I wouldn't deny that right to others." And you know what, folks? That is what religious freedom is. That's what religious freedom is, not denying. And that's what my mother and I talked about. As Catholics, what right would we have to deny others the ability to access this kind of care? I just want to show you. I love this picture of Desmond Tutu. But this is what he talks about as well. Not in this quote, but I just wanted to put him up there while I do the rest of my talk. He was instrumental in helping us get the law passed in California. I guess I don't have that much time left, and so what I will say is that, you know, the Medical Society of New York is another opponent of this bill, but they only represent 18%. The American Medical Association and the Medical Society of New York will be opponents, but organized medicine only represents a fraction of doctors, and when you look at what physicians want themselves, you find incredible support. When posed the question, patients with an incurable and terminal disease should have the option to choose death with dignity, these are the numbers. They increased from 2010, but the majority of doctors agree. I'll end by addressing just a few things that Mr. Darling said. You know, you heard stories about the Indiana hunting accident and doctor shopping, and I could spend time addressing those, but I will say that these are stories that are meant to scare you into thinking that there's some hidden reality about Oregon's experience that foretell a disaster for New York if we follow their lead. But I think it's easier to scare with a half-told story than to inspire people to bravely face the reality of death. We're talking about people who are dying. We're not talking about people who are unsatisfied with the quality of their lives. There has been no evidence from Oregon of any abuses of this law. And in fact, the research shows that even people who are living with disabilities support this law in the same comparable percentages, sometimes exceeding the percentages of people who are able-bodied. So I will leave it there and welcome your questions. Thank you.
Our fourth panelist is Dr. Ira Bedzo. He is director of the Biomedical Ethics and Humanities at the New York Medical College, which is down in Valhalla. And I think he's been there, you said, 2 years. Mm-hmm. So we look forward to what you have to say.
Thank you. Before I begin, I just want to thank Assemblywoman Sandy Galef for organizing this forum. It's truly an honor to be discussing such important issues with Ms. Carey, Mr. Darling, and Dr. Solomon. In a forum such as this, I always learn more than I could imagine, and I leave more informed than I could expect. Next, I want to emphasize that the ideas presented in this forum are not solely for the sake of intellectual edification. They affect real people and the choices that we all have to make. I mention this because, especially in a discussion over life and death, it is essential to remember that ideas should carry the weight of the actions that they promote. With the signing into law of the End-of-Life Option Act in California last week, it's becoming more and more obvious that the wave of social approval is moving in that direction. 5 states now permit physician-assisted suicide, and in general, the country is becoming more aware and more responsive to the challenges people face with respect to end-of-life care. While the ethics of the right to refuse medical treatment should not be conflated with that of physician-assisted suicide, the legal and political views regarding interpreting and enforcing advance directives has also shown how concern for individual autonomy has greatly increased. The move towards increasing the priority of individual autonomy with respect to choosing when and how one may live and die reflects the way dying has changed from the beginning of the previous century to today. In 1900, death predominantly occurred at home. Most people died from accidents or infections, as we heard, without suffering a long period of disability. Today, death predominantly occurs in a hospital, hidden from public view, despite the fact that people say they would prefer to die at home. Also today, people suffer, on average, 2 years of severe disability on their way to death. Over the past century, dying has become a longer, more alienating process. It is no longer seen as part of life. Rather, it is an adversary. From a societal perspective, healthcare spends a greater amount of its resources on the dying than on anything else. Patients with chronic illness in their last 2 years of life account for approximately 1/3 of total Medicare spending, with much of it going towards physician and hospital fees associated with repeated hospitalizations. When viewed from the perspective of avoiding these types of deaths, one could not have anything but sympathy for the idea of wanting to avoid ending one's life in suffering. In fact, as mentioned, the New York End-of-Life Options Act authorizes doctors only to prescribe medicine that leads to death for individuals with terminal illnesses, defined as incurable and irreversible diseases that have been medically confirmed and would result in the death of a patient within 6 months. It does not provide an open-ended ability to end one's life whenever one wants. However, we should also recognize how the ethical reasoning used to support death with dignity demonstrates a fundamental change in how we understand the morality of our actions as they make up a life, as well as the role of communities as they relate to their individual members. The two major ethical underpinnings used to support death with dignity legislation are the use of consequentialist argumentation and the change of emphasis to include a quality of life argument. Consequentialism is the idea that we should strive for the outcome that has the greatest benefit for everyone. In a way, it can be the most democratic ethical tool, both in terms of calculating the welfare of people, as well as prioritizing the various factors involved. However, the consequentialist argument changes our ethical perspective to look to outcomes without being sensitive to the way we achieve them. This, in turn, creates potential blinders to the way blinders to what may be the underlying cause and any potential alternative to ameliorate it. For example, in the death with dignity debate, consequentialist argumentation is used to disregard the moral distinction between the various ways in which a given result occurs. For example, because there is a fundamental right to refuse medical care voluntarily, even though it will result in a patient's death, then according to this reasoning, it is ethically inconsistent to deny anyone the right to cause his or her own death voluntarily. Just as a person is considered to be master of his or her body and therefore has the right to refuse treatment, a person should also have the right to demand treatment that produces the same effect. Just to know, certain responses by those opposed to death with dignity also rely on consequentialist thinking by raising the fear that it will cause a slippery slope, either to include the incompetent or to euthanasia. These types of responses do not challenge the ethics of physician-assisted suicide per se. They only question whether it can be controlled or not. The question of whether we can enforce the boundaries created in legalizing physician-assisted suicide is an empirical and a legal one. It's not an ethical one. Justice demands fairness. Like cases should be treated alike. Yet the ethical distinction between refusing treatment and physician-assisted suicide is, and has historically been, a very stark one, both in the legal tradition and within the medical profession, making the recent comparison between the two a demonstration of a change in ethical thinking. When refusing medical treatment, both patient and physician are passive, while with physician-assisted suicide, both are active. While death with dignity advocates dismiss this distinction, Catholic Moral Theology, the American Medical Association, and the U.S. President's Commission for the Study of Ethical Problems in Medicine accept it when thinking about the moral culpability of an action. By making this distinction, the focus is not solely on the result. It is also how actions affect people's outlooks and how habits mold character. Passivity on the part of the physician is a demonstration of the reluctant acceptance of a situation, that is contrary to his or her role as a healer. For the patient, passivity may be interpreted as exercising one's self-sovereignty while still recognizing a societal interest in the preservation of life. Activity on either part would be a contradiction either of the traditional values of the medical profession, the state interest in preserving life, or both. Also, this is a good example of where a liberty right does not necessarily entail an entitlement right. The freedom from one's interference in dying does not necessarily grant a freedom to demand one's assistance in dying. The use of morphine to alleviate pain has a similar ethical posture. If a doctor uses morphine to alleviate pain and does not intentionally attempt to lay the patient to rest, the physician can view the patient's death as an inevitability that was not in his or her control. In both of these cases, you can respond, the ethicist is creating moral loopholes to justify his position. But this isn't true. What these distinctions defend is a morality based not only on the consequence, but also on the intentions and the habits of people involved. With respect to the second underpinning, the increased emphasis on quality of life, this has made suicide a value-neutral option rather than a moral harm. When arguing that life should be about quality and not necessarily about quantity, the value of life is not measured on a common scale. Rather, each person's life is valued subjectively by the person himself or herself. When the benefit of staying alive is so diminished by illness and suffering that it is less than the value of a dignified death, the choice of how to act should be up to the person doing the valuations. This calculation does not consider the act of suicide as a moral wrong per se, which is a major change in New York's legal history. For example, while suicide was already a crime at common law, the earliest American statute explicitly to outlaw assisting suicide was enacted in New York in 1828. And in 1865, New York prohibited aiding a suicide and specifically furnishing another person with any deadly weapon or poisonous drug, knowing that such person intends to use such weapon or drug in taking his own life. In more recent history, such as the mid-90s, New York State's Task Force on Life and the Law wrote, while suicide is no longer prohibited or penalized, the ban against assisted suicide and euthanasia reflects the gravity with which we view the decision to take one's own life or the life of another, and our reluctance to encourage or promote these decisions. The New York Court of Appeals, when judging right to refuse medical treatment, refusal of medical treatment cases, uses the highest standard for interpreting the wishes of incompetent patients, because in the court's words, if an error occurs, it should be made on the side of life. Mentioning this history does not mean that I oppose the notion of change. Rather, it is to show how big a change we would be making and to raise the question of what other values it may affect. Again, with respect to the ethical arguments put forth in support of death with dignity legislation, I am concerned with the change in moral reasoning we are making when it comes to the ethics of the medical profession, since it can easily become a method of first identifying a desired good and then justifying the process of achieving it. I am also concerned with the idea that suicide is now seen as a moral neutral and can be justified when a life is no longer deemed worth living. These two moral rationales do not only have great social implications in healthcare, but in all areas of society and moral discourse. The ends do not always justify the means, and once life and death are subject to a utility or happiness function, then 6 months or 60 years is only a variable that can be manipulated. However, from a political and a social perspective, when considering New York's potential death with dignity legislation, one can not only think about his or her own personal ethics on life, the manner in which one lives it, and how it ends. As I said in the beginning of my talk, the social wave is moving towards individual autonomy and away from a communitarian perspective. Moreover, imposing legislation on those who hold a different ethical premise, especially in an area that affects the personal sphere, has a long history of failure in this country. And while the ethics behind abortion and death with dignity are not the same, we can certainly learn a lesson from the illegal abortions performed before Roe v. Wade. We do not want people attempting to take their life with dignity only to fail. We live in a community that is multicultural and diverse in the ways that people understand and prioritize certain values. Furthermore, values are reinterpreted as certain habits or public policies pervade civil society. The U.S. Supreme Court in Washington v. Glucksberg held that a law prohibiting assisted suicide does not offend the 14th Amendment, since such a prohibition is in line with our nation's history and traditional ethos. However, it left to the American voters to decide whether values once held should be changed to make room for death with dignity laws. That is why a forum like this is so important, since it allows us as concerned citizens to think about what is at stake when considering this change in ethical perspective. Yet if the reason why people want to take their own lives is to avoid the personal and familial pain and suffering that today's end-of-life care provides, then there may be other avenues to explore besides avoidance. Improved medical technology and the widespread acceptance of palliative care should be seen as areas for further exploration as to how to mitigate the harm in both one's dignity and the state's economy. Also, very important, social discourse should communicate the need to further both the rights of the individual and the responsibilities we have toward each other's welfare so that people do not have to die alone and alienated from their loved ones. I'll just conclude with the fact that the ideas of life, liberty, and the pursuit of happiness are distinct goals, and their order has always been intentional. We are now reversing that order as a country without thinking necessarily how it changes our priorities or the way we relate to each other. Thanks.
Thank you, Doctor. All right, lots to think about. I'm going to ask Dr. Solomon to just do a few minutes of just summing up some of what we've heard. If you can do that.
I'll try.
Can you do it?
I'll try.
And then the questions are yours.
Yeah, I know I stand between you and your question, so I'm just going to be very brief. I think it's fair to say that Corinne's arguments have really been, as she said herself, they're autonomy-based. They're basically saying that different people will view their options differently and that this is an attempt to legitimize aid in dying through prescriptions that make this a process that can be managed, where families can be together, where the timing can be under one's control, and that it's not that this is being pushed upon people, but it's that we want to make space for people to make this choice if they wish. So it is an autonomy argument. On the other side, there's really, my colleagues may disagree, but I think the arguments against boil down to a concern about abuse of several kinds. We heard a lot about the potential discrimination against the disabled. I'd be happy to answer questions and respond to that in questions and answers, because I think we have an interesting difference of opinion that would be fun to bring out. But that is one of the concerns in terms of abuse that's been expressed. Another potential for abuse has to do with how other kinds of social norms might change. So, for example, there might become an expectation that you don't want to be a financial burden on your family, and you might internalize that to feel that the best thing for you to do would be to opt for assisted suicide. So there's a concern that there would be some sort of slippery slope abuse at the end of the day, whether it's based on economics or based on ableist thinking. Those were on the other side. The only thing I'd like to say at this point is that I feel some sadness in a way that so much is focusing on whether to legalize aid in dying, because we have an image like Brittany Maynard and specific people who we can follow. It's garnered an enormous amount of feeling across the country. It's easy to personalize this because you can actually imagine this choice for an individual. But what makes me sad about it is that look how many of us are coming out tonight to discuss this, when in fact if we do legalize it, relatively few people will make this choice, and that the much bigger way that we can improve end-of-life care has to do with changing our healthcare system so that we're not incentivizing. Medicare will pay for endless trips to the hospital. It will pay for endless months of ventilation and endless amounts of dialysis for people who are severely demented and cannot benefit from it. But Medicare won't pay for the high-touch support that we all need as we grow older, and all the social supports that we heard about earlier, and the familial supports, the burdens on family caregivers of caring for people at home without any support in our community is vast. So while we're getting motivated to talk about whether we should legalize this or not, sure, it's an important question, but my wish would be that we could take the energy in this room and focus it on redesigning our healthcare so that we have a way for people to age in place with dignity and to have the social supports that they need. And that will require enormous pressure, perhaps from the baby boomer generation, to change where the incentives are in our reimbursement schemes. So I just want to leave people with that thought.
Thank you very much. Now, it's time for your questions if you want to come up to the microphone. And if you'd like to have a question directed to a specific speaker, and I will allow all the speakers to answer any of the questions who want to. And we want to be sure that we don't have long statements. We want to get questions out because there'll be a lot of people that will have their questions. Okay. All right, our
Hi there,
first.
Sandy. Tom
speaker.
Ferranda. We've met a few times.
Let's.
Is that on?
Is it on? There, that sounds good. All right, talk as close as you can so everybody
Right.
can hear. Speak as
Yeah, I have to say, I think it's a sad commentary on our cultural, political, and religious institutions that we have to have a forum with a euphemism, death with dignity, when you could easily call this increasing state-sanctioned killing, or when the doctor kills his patient, or when the relatives kill grandma. And I want to ask Sandy a question here, which gets back to let's take a young lady who's 18 and she's a senior in high school and she's 50 pounds overweight and she has acne and she can't get a date for the prom and she just didn't get into the colleges she wanted to get into. She's leading an undignified life, in her opinion. It's tough when you're 18 and you have the problems I just outlined. Why are we saying it's all right to kill the elderly, or the elderly can commit suicide? Why can't she take her own life? It's her body, her choice, right?
Well, I think some of the other people will answer that, but we're talking about physicians making a decision on that. So,
but I'm saying why?
I don't think a physician would say if you
But
were
I'm saying,
socially.
but the Dr. Ira here made reference
Right.
to this, that it's going to increase, and I believe it has increased suicide in Oregon. The figure I saw was something like a 41% increase. Does that sound right?
I don't know the specifics on the increase. I just want to, my response is, the woman you describe would get a different response if she had a significant disability. So although we dismissed her as not being eligible, that she would be sent away, if she had a significant disability, she would actually be considered for assisted suicide. And in fact, pardon?
Maybe from an ethical perspective, you would say that. But legally, though, according in New York, if this law passes, she doesn't have a terminal illness, so that kind of disallows her to be able to commit suicide. But from an ethical perspective, I understand that you'd say that you would have that slippery slope.
Okay, so the issue for us, though, is some conditions people have treated. So I would just go back to Elizabeth Bouvier, who was actually not about. She basically, as I said, there is an alternative to assisted suicide. It's stopping eating and drinking, and you can get palliative care and palliative sedation related to that. So Elizabeth Bouvier actually checked herself into not into a hospital. I believe it was in California. I can't recall, but she actually said, "I want to die." She had a miscarriage. She had trouble in college. A lot of this, her husband had left her. These were all things that related to her life story. But what they saw was the cerebral palsy, which is not a terminal, it is incurable. So I think one of the things that we're throwing around is incurable and terminal are different, and they can tend to get tucked away. I am incurable, both from my mother's perspective and from a medical perspective.
Yeah, well, it just seems,
All right, thank you for your question. Any other responses?
So I would respond in two ways. Is this on? Yes, okay. I'd respond in two ways. First, let me be very clear. The law in Oregon and the law that we're looking at here in New York would not allow someone with a disability who's incurable on that basis alone to request aid in dying. We're talking about people who've been diagnosed with a terminal illness and have a 6-month prognosis confirmed by a second doctor. Disability and age alone are not qualifying factors. Let me make my second point. My second point is I've heard some people say that when we talk about aid in dying, we're just using a more pleasant euphemism for physician-assisted suicide or suicide. I actually had that question with the title of the panel. Let me make this distinction. Suicide is when someone rejects life, when they choose death over life. What we're talking about here is people who are dying. They are not choosing whether to die. They're not choosing death over life. These are people who desperately want to live. What they're choosing is not whether, but how they die.
I'm not so sure that Miss Brittany
Had
a 6-month, she had a 6-month life expectancy. Her glioblastoma, I think it was. She could have lived several years.
You know, the average time between
I'm familiar
someone
with the disease.
getting medication and when they end up taking it is 47 days. Folks in Oregon don't get the medication and take it right away just because they've gotten a fatal prognosis. They take it when their suffering becomes unbearable, and so the average is 47 days, but you know, it ranges from 15 days to 1,009 days. So people wait until they can no longer bear it. And that's the people in Oregon who've taken the law. That's what the evidence shows us.
Can you help me out? 1,009 days. Is that more than 6
Sure,
months?
it is. It is.
Okay, so the individuals then got the medication, although they may have been identified as having a prognosis, they lived far longer than the 6 months.
No
which
doctor
is
will
one of
ever
the,
tell
one
you
of the
that a
concerns that we have been
prognosis-
raising is
Sure.
that is subject to individual doctors' decisions. And you
Confirmed
can-
by a second doctor. A prognosis is never an exact science. No doctor would ever tell you that. That's why people wait until they can no longer bear the suffering. That's all I can tell you.
All right, Millie?
Yeah, just on the 6-month point, that's also true, you know, for hospice as well. And we see that actually enrollment in, you're not supposed to, hospice eligibility is dependent upon the same exact diagnosis of having 6 months to live or not. And there are some interesting studies that show that once people are in hospice, they live longer than 6 months because there's so much social support and there's such a reduction in their stress. So that alone is not I don't think that's a relevant factor. There may be good arguments against legalizing physician aid in dying, but to hang it on whether people really had 6 months to live or not is not. It's going to be relevant for hospice as well, and I don't think we're going to stop offering hospice.
No, all I was suggesting was that was evidence that people lived longer than 6 months, which was one of the points that I was making. Additionally, it concerns me that the underlying, it would be very interesting to go back and study the data out of Oregon. Unfortunately, my understanding is that annually the data is eliminated and only the summary reports are available. So we couldn't actually go back and do research on the deaths that have occurred over how many years now? 17. So 17 years of data is not available for us to research, and it raises questions for me as to why that data has been erased. And maybe there's something there that we could have actually looked at and learned from.
Good point. Yes, next question.
Regina Riley, I'm from Kruger's, New York. I wanted to just mention that in this questionnaire that one of the ladies had put up on the board about the number of people who are for death with dignity, the way that it was put out there, if I got it right, was patients with incurable and terminal disease should have death with dignity, also known as medical practice of aid in dying. Now, there is a very wonderful, in fact, several Catholic hospitals and terminally ill places. One is Calvary Hospital down in the Bronx, and another one is the Hawthorne Dominicans, which is in Hawthorne, New York, who in fact aid in dying. They accompany the individual through their last stage of this part of life. And I've gone to that place many times from the time I was little anyway, and all of the patients at these places have a wonderful quality of life. They have pain medication that they need, and in the case of the Hawthorne Dominicans, they're all cancer patients, some of them with bone cancer, some of them with, which have morphine drips, which can be up and down, so they have a certain amount of autonomy on how it's to relieve them, and tremendous care of the individual. In other words, these people are seen for what we all are. We are beings, it's not what we do. I'm not a doctor, I'm not a teacher, I am Regina Riley. That's who I am. The doing and all of that stuff comes later. So the thing we start out with when we're first in our mother's womb, and the last thing we have when a good sister or someone is sending us off to the next part of life, is my being. And just going on with that, this
Do you
whole...
have a question for any
Yes,
of the speakers?
I do have a question here, believe it or not. The other thing I just wanted to mention, Terry Schiavo did not get her change of venue because there was a person who actually was a witness to her saying she wanted to live, and that never got done because they never changed the venue. And Quinlan actually lived when they took her off the ventilator, so she had a real strong will to live. That was in her being. That wasn't in her doing.
Do you have a question?
No, question is, I guess I'll have to ask Dr. Bedsoe this. In the case of Terry Schiavo, who actually was dehydrated to death, all they did, the only thing she had was a feeding tube. That was the only extra thing that they had to do for her. They withdrew food and water, but the most important thing was the water. And I wanted to know if during the dehydration process, the nerve endings become so sensitive that there's actually great, great pain.
That answer no question?
Yes, we do.
Oh, so that question I would think you would want to ask a medical doctor. I'm not a medical doctor,
I'm sorry to hear that.
but
Yes.
But she lived 14 days.
no, I hear you.
All right, Dr. Solomon will answer that question.
I'm not a medical doctor, but I do know a lot of the research on the use of artificial nutrition and hydration. And
Closer.
yeah, I said I want full disclosure, I'm not a medical doctor, but I'm extremely familiar. I'm a health services researcher, and I'm very familiar with the studies on the effects of dehydration. And in fact, dehydration does the reverse of that. It creates a form of analgesia. It's a form of analgesia. And all animals, when they are approaching death, refuse hydration because excess fluids create great discomfort, and good hospice nurses know that. They manage the drying of the mouth with ice and other ways to make people comfortable orally, but they do not provide hydration because they don't want to create extra secretions. So the dehydration can be an analgesic.
Well, my name
Next
is
question.
My name is Daniel Gallo. I'm from New Rochelle. I think I win the longest distance trophy.
I think you do.
Other than the
almost.
folks here from Rochester.
Right.
As Mr. Darling indicated, he used the word rebranding, where Compassion Choices folks used to be called the Hemlock Society. I just want to reemphasize this. And I thought I would quote from Derek Humphrey, the founder of the Hemlock Society. He said, "Increasing cost of health care in an aging society, economics, not the quest for broadened individual liberties or increased autonomy, will drive assisted suicide to the platform of acceptable practice. So I'm using your founder's words. He was a smart dude. He knew it's all about the money. Let's cut to the chase. That's why California initiated, Jerry Brown initiated a special audition, brought the legislators together to save money on Medicare and Medicaid. It's all about the money. Let me give you another example. I had to ask the question, do you not agree? Do you not all agree? I think all four of you would agree. A lot of it is about the money. Would you agree? Is it not about the money?
I don't think we can say why Governor Brown decided to support it, as we couldn't say about anybody.
But my question is, would you agree or disagree with Mr. Humphrey, the founder of Compassion Choices, formerly the Hemlock Society, which was rebranded to make it seem more palatable? What do you think about that?
We believe that the mix of managed care and the private health care system combined with making assisted suicide legal is very dangerous for people, particularly people with significant disabilities and older individuals who acquire significant disabilities, because people will look at the cost and whether or not it's being driven by managed care organizations, state Medicaid budgets, which, by the way, a bureaucrat in New York actually joked with me about an upcoming budget cycle, which is going to be bad, and he said, perhaps we should look at physician-assisted suicide as a cost-saving measure in the budget process. So it was something that was said to me today. It's disturbing. But those individual economies in our home, whether we feel like the word was used, a burden, I know that that's very, very real to a lot of people. We don't want to be a burden. And just as we were driving here, I don't drive any distance, and I was feeling bad for Adam, who drove me here to get to this, and I kept saying, I'm sorry. It's because I felt like I was being a burden, and that's just getting a ride to a meeting. So I just know that this is something that drives a lot of older individuals and people with significant disabilities who have ended up in institutions and sacrificed a lot of their lives simply because they don't want to be a burden. So I see your point. There's a lot of different aspects of this.
Sure. So I'll respond in two ways. Do folks remember the debate around death panels? So my first experience on this issue, I taught a class at CUNY on the politics of health, and I read a lot of articles by Atul Gawande, who's sort of my public health hero. And he had an article about end-of-life care and around the Affordable Care Act. And when the Affordable Care Act wanted to provide insurance coverage for doctors to have end-of-life care discussions around palliative care and hospice and what people's wishes were. The religious right came out in droves, and the former vice presidential candidate, Sarah Palin, dubbed this death panels, that we're going to kill grandma. We're going to have doctors making decisions about end-of-life care when people's lives are not worth anything. My organization, Compassion and Choices, fought like hell in Washington to get Medicare and Medicaid to pay for those discussions that doctors would have about improving end-of-life care. And you know what? Just a few months ago, we got it. And now that kind of care is reimbursed. The second point I'll make is that the Hemlock Society still exists. It's a separate and distinct organization from my own. We didn't go through a rebranding. We have a different organization. And our organization is centered around principles of autonomy and about improving end-of-life care. So I just wanted to make that clarification.
Okay, thank you. Next speaker, Jerry Morrissey. Question, Jerry?
Good evening. I do have a question. And I'm going to pose this question to any of the panel members that would like to respond. My name is Jerry Morrissey. I've been a hospice worker for 25 years, so you'll know where I'm coming from on this. I'm opposed to this proposed legislation, and I'll tell you why. I'm not going to go over all the pros and cons that have already been discussed. I'm going to raise one concern that I don't think has come up and ask you to comment on it. And my concern is that the proposed legislation makes physician-assisted suicide much more a mainstream option. That New York State's endorsement as some would say it, certainly an acceptance of this option puts pressure on the patient. And my comment is that my question to you is, do you agree that there is an issue of pressure when the state endorses a system which now presents what some people will take as a mainstream option? When you take a patient who's gravely ill and very aware of the strains on their family, and I've seen those for 25 years, suicide option may come to be viewed as the expected course. New York State sets out an option which would never have been permitted before. And for some patients, the suicide course would never have been considered, but now becomes socially acceptable and endorsed by the state. In fact, some experts in the field say it's come to be viewed by some patients as, quote, a duty to die in order to spare their families. I believe that's a real pressure that the state is considering imposing on dying patients. I ask you to consider this as a potential new pressure which the New York State can accept or reject, and I'd like your comments on the notion that I've described of pressure being opposed by the state to accept something that they never would have considered an option before.
I can go. Sure, you go first.
All right, I'll start this one off if you want, and then you can correct me, please.
No, go ahead.
So look, I don't think there's going to be any direct state pressure, but what I do think happens is whenever a new ethical line is drawn, at first there's going to be controversy, and then it's going to become obvious. You see that, I mean, with regards to the distinction between withdrawing and withholding that they used to have, and between medication and nutrition, that there used to be a distinction. Now, if you ask a medical student, should there be a distinction, there's like no moral questioning whatsoever. It's obvious that, withdrawing and withholding is the same, and everything's considered medical nutrition without any thinking about, why it's come to that. So once something gets part of the social and the medical and the healthcare conversation, there's always going to be indirect influence in terms of, oh, well, there's a reason why that option is there. That's an option that now is available. Now it's one I should consider, right? So that's how I would say that the influence comes. It's more indirect and social than it is, a coercive act by the state.
I'm not suggesting it's coercive, but I'm asking if you would believe that a New York State endorsement of assisted suicide would not create a pressure that did not exist before on a patient.
No, I think the pressures, look, being allowed to and having to are different things, right? But being allowed to and considering it heavily is not because of, it's now permitted. It's because everyone else is doing it. I mean, that sounds flippant, but you know what I'm saying. Once something becomes more popular, then it becomes more of a consideration. I think that, once again, legislation would now bring it into common discourse. It wouldn't, in terms of it being now permitted, it wouldn't say, oh, well, if the state says it, I have to do it. I don't think people will think.
No, I don't think anybody's suggesting that the state is forcing anyone to do it.
Okay, so then I don't understand the question.
No, my question is whether it creates an incipient pressure on somebody to act on what they sense is the problem that their family is dealing with.
I can try to answer that question. So I think someone on this panel raised before that in 1994, the New York Task Force on Life and the Law issued a report recommending that New York not adopt physician-assisted suicide. And so you're raising some of the same concerns that task force, which was made up of a number of different professionals, raised. 21 years since that report, though, we've learned an awful lot. And in Oregon, we have 17 years of experience with this law. And I think some people, when the Oregon law was adopted, thought that there would be a rash of suicides, that it would increase, that the number of people, would take advantage of this option. In fact, it's only a small percentage of people in Oregon who've taken advantage of the law, and there's been no huge uptick in the number of people as that's become more accepted in Oregon. So I'll just tell you that, we were talking a little bit about data available from Oregon. There are 2 reports in the back. Oregon's law has been under a microscope for the past 17 years, and there's a lot of data available. It's been studied by a number of entities. There's a meta-study on the back table, and there's also a year 17 study that talks about the demographics and about the circumstances surrounding. And so I understand the fear that you're raising, and it has been raised in the past, but we just haven't seen it play out that way in Oregon, and I don't expect it to play out that way in New York State.
We do see, however, just so that your point is well taken. We do see, however, that social acceptance does have an impact. So one of the things that people find uncomfortable to talk about is parents who kill their disabled children. So, which is something that happens. I can give you examples, basically where the father has taken the daughter with cerebral palsy, put her in the garage, turned on the car, and then closed the door, and then put her back to bed. That type of thing has actually had basically echo responses. When the family members get the support for you did what you needed to do, it does create sort of a push in that direction. And I don't think that the issue is necessarily, in some cases there are concerns about coercion, but I think you're getting to the issue that I was trying to raise. It may be very subtle. When you are feeling dependent on someone, you are watching for cues of that person, and it may just be that your daughter is particularly tired that day because she had a fight with her boss, but you may interpret that as you feeling that you're a burden to her, and that may make you feel pressured to move in this direction.
Yes.
Right, thank you, Jerry. Okay, our next questioner.
Alan Meldor, South Salem. You had mentioned about the New York State Task Force on Life and Law. In '94, they did come out, and then it was restudied again in '97, and they again came out saying, we unanimously recommended that New York State retain its prohibition of assisted suicide and euthanasia. And then it goes, after extensive study, we've concluded that legalizing these practices would be profoundly dangerous for large segments of the population. Now, you mentioned your main opponent in this whole effort to pass the law is the Catholic Church. There's someone called the American Medical Association who says, however, allowing physicians to participate in assisted suicide would cause more harm than good. Physician-assisted suicide is fundamentally incompatible with physicians' role as a healer, would be difficult or impossible to control, and would pose serious societal risks. And then they mentioned there's some 36 different medical organizations here that have taken it. I'm coming to the question. Okay. So when you say it's difficult or impossible to control, do you feel that once you pass this law, that in fact these limits might change, or they may not be held to strictly, such as in Oregon in the 10th year, nobody was referred to psychiatric examination on depression. And what's happened in Europe when we find that assisted suicide has become euthanasia? How do we control this as a creeping event that will come down the line? That's my question.
So there were a lot of questions in there.
Well, it was just basically, how do we control this thing? Because we've seen it in other places where it doesn't happen.
Sure.
Oregon, there was nobody counseled. And we know they had to be depressed.
Well, you're citing 1 year of data. In fact, last year there were folks that were referred for counseling. But folks who were determined to not have the capacity to make the decision because it was impaired by depression or other psychological conditions. But let me go back to the other thing that you said. A couple of things that you said. The way that you control changes in any law is having a public dialogue about it. The Oregon law has remained unchanged. And there have been none of the cases of abuse that the Task Force on the Life and the Law thought would happen. Profoundly dangerous are the words that they used in their report. But in fact, all of the things that they predicted might happen from the Oregon law did not come to pass, and the Oregon law has remained unchanged. If there were a move to change that law, Oregon would have the same kind of dialogue that we're having here, and I would encourage that because I think it's important that everyone understand what it means. As for the American Medical Association opposing this, the American Medical Association was one of the last organizations to come around when it came to allowing folks the ability to withdraw life-sustaining treatment as well. Sometimes it takes a while for institutions to change, and sometimes it takes individual medical doctors to change their institutions. And I think that that's what we'll see here in New York and across the country, is that individual doctors will change the AMA.
You said the law hasn't changed in Oregon. My question wasn't really, has the law changed? Has the adherence to that law changed? And that's what we see, and I have a book full of different instances, so that's the question. I'm afraid that you can make a law, and then the doctors might not go along with exactly, and the fact that nobody had psychiatric treatment or examination that year. Somebody had to be depressed. Okay.
I think this comment and the comment before share something in common, which is that both are concerned about a slippery slope, how things might go wrong if this is legalized. And I'd like to point out that no matter that if we do pass this in New York, that we not make the mistake that the Vermont legislature's made. And I'd like to have this be something that's really could come out of this hearing. In most of the other states where I think in all the other states where it's legalized, there is continued monitoring, because that would speak to this question, especially the last person's comment. There's continued collection of data that's mandated along with the law so that we can study it. But in Vermont, they sunsetted the monitoring. So the Vermont legislature legalized aid in dying, but they expressly said that after some number of years, and not that many, I think it's 3 or 4 years, that the state was to no longer collect data. And I think this was done for really confused, on the basis of very confused reasoning. The state legislators argued that continued data monitoring would be an intrusion on the privacy of the doctor-patient relationship, and that the state should not be in the business of collecting the data. And I think that's a tragic mistake, because there are legitimate slippery slope concerns, as these last two commentators have just made. We can still legalize it for a variety of reasons, but to say that we're going to legalize it and not monitor it is, in my view, really short-sighted. And I hope that New York, if it does legalize, will not follow suit with Vermont.
I just want to, the question was, I think that's a fair question about folks who are depressed. The thing is, depression is not just something, I mean, we all as lay people think, oh, my best friend's depressed. It seems like it's something pretty straightforward. You know it when you see it. But it's not actually that easy to diagnose. My husband happens to be a counselor. And what they found actually in Oregon is only 6% of Oregon psychiatrists are confident that they can diagnose depression in one visit. So, but that is what is given as the consultation. So depression actually is a much longer term issue, and it is something that needs to be, you need to actually build a rapport with the patient. So one of the concerns that I have is that there is a potential problem here related to people who are depressed, that there are issues in Oregon that are not being surfaced, in part because we may not actually have the infrastructure there in Oregon to identify those issues.
Good evening, everybody. My name is Mel Tansman. I live up here in Mohegan Lake, but I'm also the executive director of Westchester Disabled on the Move, which, like the Center for Disability Rights, is an independent living center for people with disabilities. I promise that I will have a question that will be directed towards Ms. Carey. However, I do think I want to make a few points that are based on my own personal experiences, one very, very personal, and one having to do with professional. And the question in the end is going to be the appropriateness of physicians to be the gatekeepers, and the issue of ableism, and the issue of the slippery slope, which I think Dr. Solomon pointed out, it is a valid concern. Real quick, when we adopted my daughter when she was 3 years old, several months after she was adopted, she developed juvenile rheumatoid arthritis in a very terrible condition of it. High temperatures, a long stay in the hospital, and when we took her to see a physician, a very well-known physician, a rheumatologist, his question to us was, why don't you just send her back? P.S. She's now 20 years old, and the rheumatoid arthritis is totally no sign of it. The other thing, and this was a more professional-based experience I had in the last year. One of the things our center does is help people get out of nursing homes. Young man at 27 years old had a motorcycle accident causing a brain injury and also the amputation of his right arm and right leg. He was told when he went to a rehab facility that rehab was useless, that because of the TBI, the signals from the brain were no longer going to the other parts of the body. He could have done two things. He could have accepted that, become extremely depressed, and probably want assistance with ending his life. Or he could have gone and tried to get a second opinion. Luckily, he tried to get a second opinion, and the neurologist said to him, no, all the signals to all the parts of the body are still going there. All those systems are working. So thankfully, he had to force the nursing home to give him the rehab that was appropriate. So I guess my point is, and my question is, what makes physicians who have, some of whom have very ableist attitudes, the most appropriate gatekeeper? And let's not also forget that, AIDS used to be a death sentence, and that wasn't too long ago. So that's my question.
So your question is, what makes physicians
Why,
an appropriate
why are they
gatekeeper?
appropriate when some of their attitudes may be, ableist or prejudiced in many ways?
I think my answer is simple. They're not at all. Physicians are not the gatekeepers here. Individual people are the gatekeepers. They're the ones that make the request for the medication. They're the ones that have to express the desire to take it. And as I said before, in the Oregon experience, folks who get the medication then make many other decisions afterwards. Sometimes, 2/3 of the time, they end up taking the medication and ending their lives, but it is ultimately an individual. I think you also were asking, about whether this is an appropriate role. I think the examples that you gave, those are completely inappropriate behaviors for physicians. And I don't think you'd find a person in this room that disagreed with you. Those are horrible responses to terrible situations. And I'm glad that both of these individuals pulled through in the end, and thank you for raising them. One of the arguments that we hear is that it's a physician's first duty to do no harm. And I think what I would ask folks to consider is, what does that mean when someone is suffering and is going to die? Is it harmful to refuse to help that person? The suggestion that suicide is an option without this law, that someone can take a gun or use some other violent means to end their lives, is just, I find it insensitive. I'll leave it at that.
And this is Bruce. I just want to, the point I was trying to make was not that you should take a gun and violently end your life and make your family's life a living hell in the aftermath. That is not at all what I was suggesting. Voluntarily refusing to eat or drink and receiving palliative sedation and palliative care at the end of your life is an option that currently exists. It is an option that reaches the same goal. It may not be immediate, but it also assures that individuals are not coerced in the process. So there are clear examples where, like Kate Cheney, who was 85 in Oregon, she was actually, when her physician wouldn't prescribe her the lethal dose, the managed care organization made a referral to one who would. And when she got her second evaluation and there was a question raised, the daughter became angry. And it was clear, ultimately, that the daughter may have had a coercive influence on this individual. It was noted in the record, but she was still given the medication. Because it's self-administered, no one knows whether she took the medication herself. But what we do know is she took it after she was placed in a nursing facility for a week. So there are clear issues of coercion, the things that people fear. There are minor things that people may do that are not intended to be coercion, but may signal to someone who's feeling a burden and dependent. So I just want to acknowledge that. And then we had mentioned that people needed a terminal illness. I just wanted to acknowledge there are some intersections on this. ALS, let's just take that as an example. ALS, Lou Gehrig's disease. A lot of people may think of that as a terminal illness, but it actually is a disability as well. And where the prognosis is unclear, that is a person who could otherwise may have lived a life that was cut short. And frankly, just so that you're clear, okay, 16% of the folks in year 17 in Oregon had ALS.
So this is looking forward a little bit, but in countries that have legalized physician-assisted suicide, the debate has often turned to questions of access to this right by people who live with persistent, chronic, and incurable mental illness. And in some countries, people living with mental illness have chosen to die with dignity via physician-assisted suicide, usually with additional safeguards in place and after having exhausted all other treatment options. But tonight, as is often the case, we speak of screening out those who live with mental illness, we dehumanize them using legalistic competency language, and we suggest that these people abdicate their right to decide how they live and how they die. Why are we treating these people as incapable of choosing dignity in their deaths? And ethically, how can we make this distinction without simply relying on the 6-month terminal diagnosis or prognosis stipulation? Thanks.
All right. I want to thank you for that question. I think it's a brave one. And I think that from my perspective, from our perspective at Compassion and Choices, the legislation that we're looking to pass in New York is about autonomy, but it's also about ensuring that folks that at the end of their life have an option to choose the way that they die. These are the issues that you're raising are different, and I will say that they deserve fuller debate, but that's not the End of Life Options Act that we're talking about here. But I'll allow my fellow panelists to address it. Anybody want to comment, or we'll go to the next?
There's been actually a very interesting conversation between individuals in the psych survivor ex-patient consumer community and individuals involved in Not Dead Yet, where they've actually found a lot of common ground around concerns related to loss of autonomy, where physicians actually weigh in and take control, and the concerns about coercion. So there is I don't know if she's still here. I lost her.
She's back here.
There is if you want to connect afterward, I can maybe engage you in that conversation and connect you with folks, because there is a real significant conversation within the disability community.
Interesting. I just want to share something with you that I think you will also find quite interesting. Quotes, whatever its motives and means, direct euthanasia consists in putting an end to the lives of handicapped, sick, or dying persons. It is morally unacceptable. Thus, an act of omission, which of itself or by intention causes death in order to eliminate suffering, constitutes a murder, gravely contrary to the dignity of the human person and to the respect due to the living God, his creator. The era of judgment into which one can fall in good faith, and I'm going to just say here, I think everybody in this room is here in good faith, but we do make mistakes. The era of judgment into which one can fall in good faith does not change the nature of this murderous act, which must always be forbidden and excluded. I wish I could claim credit for that, but that is paragraph 2277 from the Catholic Catechism, as everybody else in the culture. So I think the failures of members of the Catholic Church don't justify behaviors. They're sad, they're failures. My question, though, it has haunted me, even dealing with the issues of life with the preborn child. How do physicians who take the Hippocratic Oath and promise to do no harm, and you almost stole my thunder down there, Ms. Carey, but I'm asking the question anyway, how do physicians justify the idea of assisting someone in taking their life when they promise to do no harm? We are all going to die.
So I'm not going to address your first point, which is about Catholics and our views on this. I will say, I will go back to my earlier statement about religious liberty and religious freedom and say that 39% of New Yorkers are Catholic, and we don't have the right to impose our religious views on the rest of New York. And I think that's sufficient. But you cited the Hippocratic Oath, and I'm glad you did, because it gives me the opportunity to get to something that my time limit did not. And that is, less than a handful of modern medical schools have graduating medical students take that oath. If they administer any oath at all, it's either a modified version or it's some other professional oath. But let's stay with the Hippocratic Oath for a moment. You know, everyone knows that it's do no harm, but if you look at the time during which Hippocrates penned this oath, this was a time of tremendous upheaval in Athens. People were being poisoned left and right, and in political intrigues, and doctors were conscripted to poison others. Since the part about poisoning follows directly from a sentence that reads in translation, "From injustice I will keep them," it's probably more about vowing to refuse to take direction to poison others than anything else. And so I would just challenge us to look beyond some of those words and think about what translation means. What I said before is that what is doing no harm when someone is suffering? Is it doing harm to refuse to help?
And then I would just ask, I hear the issue though is, are you doing no harm to the individual patient, but what about the other people who are collateral damage to the policy? So we are not in the individual medical exam room or the hospital room or the individual patient's living room. We are looking at changing public law that would provide immunity to doctors and family members related to helping someone or having someone die. And that's, to me, when we're looking at the question of do no harm, what about the other individuals who will face harm, so that some individuals can have an extended right to control the hour of their death rather than have it within a period of weeks? We do have palliative sedation, voluntary withdrawal of eating and drinking, which give you control over your death. It's just not down to the hour.
Okay, one last question. We're supposed to be out by 9 o'clock, so if you could just do a quick question for us.
Well, I have a series of them.
No, only one, so take one
Well,
out of your series, if you would.
I'm Dr. Botino. I am Vice President of the Westchester County Medical Society. We've met. So I have to ask some of these questions because I think they're important. And I'll open it up to the audience completely, too. How many of you, due to your own direct actions, have caused the death of another human being? Raise a hand.
Yes.
Okay. Well, just ask one person. How many of you have held the hand of someone dying? Well, let me take it back. How many of you have held the hand of 15 people at least while they're dying? 15? Well, hospice carers, nurses? Okay. How many of you have held the hand of 100 people dying? 100. 100. How many of you have held the hand? I didn't see any hands go up. How many of you have held the hand of 1,000 people dying? And I have. Okay? So I suggest that I find it disturbing that people think that they're experts on death and dying and what ought to be done when not one of you has done that. Now, here's my question for Sandy.
You started at 15.
Here's my question for Sandy.
I would
Okay.
like to comment, by the way. I did ask the Medical Society, the state of New York, if they would provide a speaker for this event, and they decided not to.
You should have
They
asked
said,
us.
well, we did ask the Westchester.
No, Westchester County, I would have heard about it.
I did call, yes. Yes, I did call.
Who did you talk to? I'm really sorry.
Your executive director, whatever.
Really?
Yes, yes. So
Okay,
I'm
so-
sorry. I did call.
So my question, actually, Sandy, is this reminds me of the Affordable Care Act. On this panel, there's not one doctor, and that is disturbing to me because just like on the Affordable Care Act panel that created it, there wasn't a single doctor, and it disturbs me that there's no doctors
Well, remember,
involved.
I told you that I did ask.
Yes. And
And
I'm
they
sorry.
said no.
If I would have known, I would have. Janine didn't tell me. I would have told her that I would have been here. All right.
All right. Well, maybe this is not the only panel. Maybe we will have many panels as we go on. I'm sure there will be lots of events like this. So I just want to thank you all for coming. I want to thank all of our panelists for all of their participation. Coming from a long distance is very special also. So thank you. Thank you for attending.